Good morning. Welcome to the December 19th Public Health Nursing ITV. Happy holidays and to you and yours. We've got a very full ITV this morning with a lot of great information to share with the public health nurses both here in Frankfort and across the state. Our first presentation is a pertussis update, so we also hope that regional EPIs are able to join us for this presentation. And ERRT hours, 1 hour will be provided for this presentation as well. I did attach the ERRT attendance verification form with the handouts that I sent out on Tuesday. So if you do use this presentation for CEs and ERRTs, please go through the usual process to submit that documentation form. We'll go ahead and get started. It's my honor to introduce our CE speaker this morning, Dr. Robert Brawley, who is the Chief of the Infectious Disease Branch in the Division of Epidemiology and Health Planning here within the department. Dr. Brawley is going to provide a very important update on pertussis for you all. There's been questions, and I understand some outbreaks, and so it's very timely and relevant, and Dr. Brawley is certainly the expert on this topic. So thank you, Dr. Brawley, for taking time out of your busy schedule to speak with us today.
Okay. Well, good morning, everyone. It's timely that we talk about pertussis today. Not only are we having cases in the state of Kentucky, but we're also going to have a new update to the case definitions for pertussis in 2014, and we'll cover that as part of our discussion. The objectives this morning is that we're going to discuss the current epidemiology of pertussis in Kentucky and in the U.S., including some information about patient demographics, disease symptoms, and disease transmission. We're going to describe the period of communicability and some recommended antibiotic treatment. We're going to go over the 2014 case definitions for both confirmed and probable pertussis cases, and there is some new information here. And then lastly, we're going to discuss some new guidelines for contact investigations and post-exposure prophylaxis. We have distributed those guidelines in draft form, and those drafts predated the 2014 case definition update, so we'll have to make final changes in the text of those guidelines. So pertussis is also known as whooping cough, and in China, as the last bullet shows, it's known as the 100-day cough. Without treatment, cough symptoms can last up to that long. There are 3 clinical stages of pertussis. The total spectrum can last somewhere between 6 and 10 weeks. Pertussis starts off with the catarrhal stage. It looks no different from any other common cold-like illness. It lasts 1 to 2 to 3 weeks, and then is followed thereafter by a stronger cough that is called a paroxysmal cough. And we'll share some videos, I hope, of those coughs this morning. But these coughs occur in fits. They're very serious coughs. They cause hypoxia in infants and possibly in adults even who have chronic pulmonary or heart disease. What characterizes a paroxysmal cough is that, and hopefully the videos will show this for you, is that it's a continuous expiratory cough, or the coughs have only small puffs of inspiration. And after the person is almost exhausted with the coughing spell, they take an enormous inspiration. And after the infant period, and some infants do have a whoop, but particularly adults and adolescents and children will have a whooping sound. There's often post-tussive vomiting. And then there's a convalescent phase. Pertussis is most serious in infants and other persons who have chronic diseases that would be made worse if they would get a severe cough illness. The incubation period is 5 to 21 days, but is usually somewhere 7 to 10 days. And there is a seasonality.
She just didn't like the way you were handling the vote.
There it is. Are we moved?
No, you're not muted.
No.
Well,
Oh, is there audio in there?
Yeah, right there.
yeah, we'll see if we can make the audio louder. Oh. We'll try this again. Well, hang on. These are going to be, I hope, to show you a cough, paroxysmal cough in a child and then one in an adult. Okay, we're going to try this one last time, and thank you.
Chez l'enfant, c'est épuisant, hein?
Pertussis has, it causes very thick secretions, so you can see how much difficulty that child was having handling those secretions. I hope we're going to be able to show this adult.
Register under a state, at the state site. There's CEU.
Well, that's going to continue. You can see that if this adult had severe COPD or if he had severe heart disease, that he would be in real trouble.
Just let you hear two versions of an actual
You're
cough.
on by telephone. Can you make sure that the mic on your telephone is muted, please?
Yeah, we have some folks that are not muted, so thank you. Pertussis is a respiratory illness. It's spread by breathing in contaminated respiratory droplets. So droplet transmission is primarily the mode of transmission. Droplets are 3 to possibly 6 feet that they can be coughed. So that's more or less the infectious zone around a person who has a pertussis illness. It's also possible in child care centers or homes for contact with articles that have been contaminated with these droplets to result in the spread of infection. Adolescents and adults that have a prolonged cough illness can be reservoirs of disease in the community. It's highly infectious. 80% of household contacts get pertussis. And unfortunately, this is a disease where acute infection in the absence of immunizations does not result in lifetime immunity. There are only 2 recommended laboratory tests presently for the diagnosis of pertussis. The culture, the second bullet, is the gold standard. It takes 7 to 10 days, and it's problematic in that pertussis is a labile organism. It's very fragile in terms of handling, and so sometimes a negative culture may not truly be negative. It just may be that the organism died before it got to the laboratory to be processed. Primarily, PCR polymerase chain reaction tests are done for pertussis. You can do them on NP swabs or NP aspirates, and these tests do not require the presence of viable organisms, so they can be positive even after several days of antibiotics and up to about 3 weeks after completion of antibiotics. We do not recommend either serologies or DFA, which is the direct fluorescent antibody test. DFA, in spite of it having an antibody in the name, is a test done on nasopharyngeal secretions. We do not recommend that either of these tests be used for laboratory confirmation or case confirmation. Interestingly, we got a DFA test result sent to us from another state just this week. This shows the graph of the incidence of pertussis cases in the United States since 1922 through 2012. You can see that we now have about 50,000 cases in the U.S., but at one time back in the 30s, the number of cases annually was 5 times that number. So if you can just imagine 5 times whatever's happening in your county now, that was the burden of disease in the pre-vaccine era. You can see that in the 1950s, after vaccination was introduced into the healthcare, the incidence declined rapidly. And then there were controversies because of the immunization causing adverse reactions, including local reactions, high fever, and persistent crying, that manufacturers developed a new vaccine called DTaP in the late 90s. And then TDAP was later introduced a couple of years ago. As you can see that from 1990 onward, we've had a slow increase, and then in the last 5 or 6 years, a fairly marked increase throughout the United States and throughout the world. These show the incidence of pertussis in the U.S., and it's especially a disease of young children under a year of age in terms of the highest incidence. In 2011, 2012, you can also see that there's a peak in those that are 7 to 10 years of age. This shows the data for just 2012 that the incidence for those less than a year of age, 126 per 100,000 persons, and that's more than twice the incidence of any other age group. And at least in that year, the most cases occurred in children that were 11 to 19 years of age, but their incidence was about a third of that of infants. Pertussis can be a fatal illness, and those that are particularly at risk are infants, particularly those under 4 months of age, or this has 3 months of age, but and then those that have severe diseases that would be made worse if they get pertussis, they can have fatalities too. So at least in 2012, there were 20 total fatalities reported to public health. 75% were in infants under 3 months of age, but there were 2 adults that were 55 and older. This is Kentucky since 2000. I put this to show you the baseline, at least pre-2008, when the cases really began to spike, not only in Kentucky, but throughout the United States. The median number of cases reported from 2000 to 2007 was 80 per year. Since 2008, we've had cases throughout the state. Our highest number reported was in 2012, but we're going to have our second highest year in 2013. We're not even at the end of the year, and we've already had a record year in terms of being above the baseline. The median number of cases for to date from 2008 is 264 per year. You can see here that our rates in Kentucky were below the national average until about 2008, 2007, and we, in 2012, were above the U.S. rate. In Kentucky, the 2012 cases, primarily, you can see we have a bimodal distribution of infants and then individuals 19 and older, but 23% of cases were in children 0 to 2 years. This shows the map, and the gradations of pink really are the counties that have had cases in 2013. And Dr. Humbaugh uses the term community immunity as a methodology of controlling and preventing pertussis, and you can see that if the pink represents the status of our community immunity in Kentucky, it's not very good. I didn't count the number of counties that were affected, but it looks like more than half of the counties have had pertussis cases in 2013, and the darkest colors is more than 25 cases. Well, what are some of the reasons why pertussis has increased in the last several years? Well, one, it's cyclical in nature, as that graph from the 1920s forward shows. We also have better test methods. PCR is easily done, and I think providers are getting more expert at doing those NP swabs and sending the specimens to the laboratory. So, and we know that doctors are testing more. When they get one case, their index of suspicion goes up and they do more frequent testing. Probably the most strong factor is that there is waning immunity from earlier vaccinations. What we know is that the DT-AP vaccine is less effective than the DT with pertussis vaccine. And we know that from a couple of studies that have been recently reported because of the large outbreaks in the West Coast, both in Oregon and in California. And it was shown in Oregon that if you did a case control study and compared children that developed pertussis with a matched group of children that did not, that if the children who did not get pertussis had had any doses of DT with pertussis, that they were protected from pertussis illness better than the children that had only received the acellular pertussis vaccine. Then a large study from California showed that after the 5th dose of DT-AP, immunity began to wane fairly quickly, and there was a 50% increase in risk for illness every year for the 5 years after the last dose. And that's about the time we start seeing cases again in middle school. The concept of community immunity, that there needs to be a herd immunity of individuals in the community to protect individuals from exposure to pertussis, is, I think, a sound policy. But we just have too many individuals that are still susceptible. We either have children that are 7, 8, and 9 years who maybe didn't get immunized or only got partially immunized, but we have no pertussis vaccine FDA approved for those age groups. TDAP was only recently approved in 2011 for use in adults age 65 and older. And unfortunately, there's just a diffusion of innovation slowness in healthcare. And so there's probably a lot of individuals who are 65 and older who've not gotten TDAP as part of their routine healthcare. It's covered by Medicaid. They should get it, but we know that many do not. And then, we don't have a comparable adult program for the children that's similar to the VSC program for children. So poor adults, people who have not health insurance, have really had no healthcare option to cover adult immunizations. Individuals who have pertussis who are contagious 10 days before the cough until 3 weeks after the cough. They can be made non-contagious by appropriate prescribing of antibiotics and taking those antibiotics for 5 complete days. They can go back to work or back to school on day 6. Or if they have coughing for 3 weeks, then they are not contagious anymore. They will continue to cough, as was described earlier, that this can be a 100-day cough. So 3 weeks won't be the end of their cough, but it will be the end of the contagious period. This is a graphical depiction of that from one of the CDC guidelines that shows that the period of communicability precedes cough onset and lasts 3 weeks after cough onset. We know that treatment reduces infectiousness, but after the paroxysmal cough develops, it will not make the cough go away. And we all have heard stories of individuals who have gone back to their primary care physician because they were treated, but they're still coughing. And there's concern that this is still pertussis, but it's the pertussis cough and not likely re-exposure. The antibiotics that we use for both treatment and for post-exposure prophylaxis are the same medications and the same doses for both purposes. And I won't cover this chart. It's in the Red Book and it's in CDC guidelines, but it's in your notes. One thing I will say about this is that there's only 3 time periods for the medication. So there's a 5-day dose with azithromycin, 7 days with clarithromycin, or the other recommended treatments are 14 days, whether it's erythromycin or trimethoprim sulfamethoxazole. So if someone comes and says, my child was treated for 10 days for pertussis, their medical provider did not use the right regimen or the right duration of treatment. It may be both. If you have pertussis and you have just been exposed and have been given post-exposure prophylaxis, there's no restriction from work or school for that individual. They need to take their antibiotics, but they don't need to stay home. Individuals that are symptomatic, they're having a cough illness, they should stay home until they complete 5 full days of medication that's appropriate for pertussis. And they can return on day 6, or if that happens to fall on a weekend and it's a school child, they can return the next school day. If perchance they're allergic or parents refuse medication to be given to their children, then they should remain home until 3 weeks of illness has progressed, and then they would be no longer considered contagious and can go back to school or work. We know that individuals are most infectious during the initial phase of illness, the catarrhal stage, and during the first 3 weeks of the cough phase. The incubation period is 21 days, so if someone comes in and they've been exposed, then there's no indication for giving post-exposure prophylaxis if they come in on day 25 or day 30, as an example. We also recommend following people for a minimum of 2 incubation periods, which would be 42 days, to assure that they're asymptomatic if they're exposed and unimmunized. So now we're going to describe the 2014 CDC case definitions, and we'll go through these fairly quickly because they're in your notes, and I'll primarily highlight what's different from what's been used before. These are the clinical criteria described. They're similar to, they're identical to what we've had before, but we have one new criteria. And so in the absence of a more likely diagnosis, we have to have a cough illness lasting 2 weeks or longer with at least one of the following signs or symptoms. So a cough illness with none of these doesn't meet the clinical case definition. Or a person with no cough illness, they don't meet the clinical case definition. So it's a cough illness that's prolonged paroxysms of coughing, inspiratory hoop, post-tussive vomiting, any of those. Now we have a new criteria, apnea in children with or without cyanosis. That criteria is only for infants aged less than 1 year and it's new in the 2014 case definition. The laboratory criteria are unchanged. It's the isolation of Bordetella pertussis from a clinical specimen or positive PCR, or we can have an epilink case, so we have contact with a laboratory confirmed case. And there is a note here that in individuals that have a positive PCR in contact with an infant less than a year, but they've been coughing less than 14 days, that's called a probable case. We've been having a probable case definition for Kentucky similar to that for a long time. So a confirmed case, unchanged from before, an acute cough illness of any duration with isolation of the organism is a confirmed case. So a confirmed case that's PCR positive is a case that meets the clinical case definition. Has to have the cough illness prolonged, one of the associated signs or symptoms, and apnea for infants is new in this definition, and they have to have a positive PCR. We can also have a confirmed case that is epilinked. It's a case that meets the clinical case definition and has had contact with a laboratory confirmed case, but there was no laboratory confirmation for the person with the cough illness. That's an epilink case. There's also a probable case in that they meet the clinical case definition, but they have not been had any laboratory testing. What is new for 2014 is we have a new probable case definition for infants under a year, and that is that they can have an acute cough illness of any duration with at least one of the trigger signs or symptoms, particularly apnea with or without cyanosis, and they have a positive PCR. And then there's a probable case for infants where they're epilinked. They have an acute cough illness, one of the trigger signs or symptoms, and they have a contact to a lab-confirmed case. In Kentucky, we've been using this criteria to describe a probable case. It's a case that meets the laboratory or epilink case definition, and they've not been coughing yet for 2 weeks. So what we've recommended to local health departments and regional epidemiologists is to treat this patient as a confirmed case in regards to pursuing a contact investigation. Some health departments have had staffing where you've been able to follow up and call back and determine if the child coughed for 2 weeks or longer. We now know that some health departments do not have the staffing to do that, but we still would recommend that these be treated as a confirmed case in regards to pursuing a contact investigation. A probable case that meets the clinical case definition but doesn't have the lab confirmation, does not have an epilink to a lab confirmed case, we don't recommend that those be investigated. So now we'll go with some of the guidelines that we've distributed in draft form for several weeks now. And these are new CDC guidelines, and I think what's important in talking with local providers is that these guidelines will differ from what is presently published in the Red Book. As y'all know, pediatricians use the Red Book published by the American Academy of Pediatrics, and these also differ from the latest edition of the CCDN. So if someone pulls that book out and says, well, that's not what it says here, that's right, it isn't. But these are new recommendations. We'll have to refer them to this CDC website. But these recommendations have evolved from public health practices for pertussis outbreaks on the West Coast, particularly in Oregon, California, and Washington, where they had several thousand cases. And it also has been recognized that in spite of the increasing incidence and apparent widespread community transmission, the extensive contact investigations that were done in the past and wide use of post-exposure prophylaxis didn't seem to be a very effective use of public health resources in controlling the outbreak. And this is because that there's no data to indicate that giving everybody antibiotics, giving all the classroom, giving all of the people in the workplace, as an example, would effectively control or limit the scope of the outbreak. CDC, as you've seen in other messages, is also very concerned about both the overuse of antibiotics and about the development of resistance to antibiotics when they're widely prescribed for indications that antibiotics won't treat, like a common cold or sinusitis, or if they're overused for something like a pertussis outbreak. So CDC now supports the targeted use of post-exposure prophylaxis for persons that are personally at high risk for developing pertussis, or for persons that are healthy but they live with or have otherwise have close contact with someone who has a chronic illness that would be made worse if they develop severe pertussis. So we'll have some examples. So in these new guidelines, CDC supports the use of post-exposure prophylaxis for all household contacts of a pertussis case. That's not new. We've been doing that all along. And then they support the use of PEP for persons who personally have a high-risk illness or condition that would be made worse if they were exposed to infectious pertussis. But you have to give the PEP within 21 days of the exposure. And lastly, CDC supports the administration of PEP to healthy contacts who themselves either have someone at home with a high-risk condition or a pregnant woman, an infant, that would be made worse if they get pertussis. So some of these high-risk persons include infants under 12 months of age, particularly newborns and infants under 4 months of age, women in the third trimester of pregnancy, and then persons with pre-existing health conditions, chronic conditions, that if they get pertussis and have the cough illness that you saw in those two examples, they would get severe illness from pertussis, but compounded with an exacerbation of their chronic condition. So a child with cystic fibrosis, an adult with cystic fibrosis, someone with severe chronic lung disease, someone on supplemental oxygen, someone with bad asthma that needs to be treated frequently, someone with respiratory insufficiency, severe heart disease, cyanotic heart disease, someone that has severe immunosuppression are examples of individuals that we now want to protect. So these are the target audiences for protection against pertussis, and PEP should be targeted to protect them. There is one example where PEP should be administered to everyone in the high-risk setting, and that is when the high-risk setting includes infants under 12 months of age or women in the third trimester of pregnancy. And some examples used in the CDC guidance is that this could be a newborn ICU, it could be a child care setting, it could be a maternity ward. We know that the investigations are done by y'all in local health departments and by regional epidemiologists, and you have to get the, great cooperation from a number of people in the community, from both medical providers and child care centers. But now what we're wanting you to do is elaborate contacts, but focus efforts on identifying the high-risk close contacts that would benefit from post-exposure prophylaxis. If contacts are symptomatic, we still recommend that they be evaluated for pertussis disease, and then they would be returned to work or school, based on their physician's advice. As we said earlier, high-risk close contacts and healthy close contacts who themselves have someone at home or in their immediate environment who are high-risk persons and they don't have symptoms, they would be recommended to get PEP to prevent them from becoming ill and then exposing the high-risk person to clinical pertussis. And this is whether they've been vaccinated or not. So who's a close contact under these the new guidance? family members, household members, those who spend many hours together and sleep under the same roof in the household. And then someone who has direct contact with the respiratory, oral, and nasal secretions of a symptomatic case. And these can occur in a variety of settings, both in child care, work, school, and then healthcare workers, knowing that the cough distance is 3 feet. If a healthcare worker is caring for a case of pertussis, they're not wearing a mask, and they have someone cough or sneeze in their face, and the person has pertussis, they're a close contact. In a school setting, and this I think is controversial at times, it's those who share the same confined space in close proximity with a symptomatic case for an hour or more. And I think particularly an example would be a motor vehicle. If someone was on a sports team or some other school group and they went together somewhere in a car for more than an hour, that serves as a close contact. As we described earlier, there are high-risk settings where close contacts are the infants and women in the third trimester of pregnancy in those settings. So now the new methodology is to initiate a contact investigation on all confirmed cases, probable cases in adults, and probable cases that meet the probable case definition for Kentucky. So they have a positive PCR, but they're coughing less than 2 weeks. We need to exclude the old cases from school or work until they've been treated or evaluated and certainly cleared to return. Identify close contacts, educate everyone widely about signs and symptoms of pertussis, and then recommend that these high-risk close contacts, that if we have close contacts that are having a cough illness, they may have clinical pertussis, and they should be excluded from school or work until they've been evaluated. And then the health departments need to provide recommendations about PEP for those high-risk close contacts that were listed on the previous slide, or for healthy people who live with those individuals or otherwise have contact with them. And we want to prevent the healthy person from developing pertussis and exposing the high-risk person. So we know that you're going to have to work with child care settings, schools, and employers about health messaging. In these draft guidelines, we have some example letters, templates we call them, for communicating to schools. We also have some example content for email messages or for posting on school or employer's website. And also a script for an auto dialer for schools. Now, in terms of, we know that we're getting from LabCorp particularly electronically reported lab results for pertussis antibody tests. And our recommendation is that those individuals not be investigated, that these lab tests, whether they're pertussis antibody or DFAs, cannot be used in the clinical case definition, and so we cannot use those tests to classify a person as having pertussis at all. I think it would be important to determine if those individuals are a contact to a lab-confirmed case. If they then have a cough illness that's 2 weeks or longer, they could be epi-linked and confirmed as a case of pertussis. But we don't use the positive antibody or DFA results. I think it would be important to educate providers about the appropriate lab tests, and I know you all have done that repeatedly, but we still have providers that are ordering the antibody tests, and I really don't know why they're doing it. And then as part of the contact investigation, we need to provide pertussis-containing vaccinations to individuals that are not up to date on immunizations, and recommend that community providers also increase the use of pertussis-containing vaccinations. And that is to increase community immunity. So, as I said, we've distributed a final draft version. Since it was distributed, the 2014 case definitions came out, so it's going to need a bit of revision, but it does have several appendices with example documents that can be used for communicating to parents and medical providers about pertussis. So in our draft guidelines, we also have recommendations for providers that are in those letters. But what we want community providers to do is to collect NP swabs or aspirates and do pertussis testing with PCR or with pertussis culture. We would like them not to order the antibody test or the DFAs. But we also do not want them to delay treatment if they clinically suspect the person has pertussis, waiting on these antibody tests. We do want them to keep a symptomatic child away from school or an adult away from work until day 6 after treatment has begun. So if they're on one of those 14-day regimens or they're on the 7-day regimen with clarithromycin, they can still take their drug and go back to work after or school after day 6 or on day 6. Then they need to communicate with the school about their clinical decision making or the work site. We've recommended in the guidance for providers that they provide post-exposure prophylaxis for household members of patients with pertussis and remind them that you have to give PEP within 21 days of exposure for it to be effective. So if perchance they see a patient that's been coughing more than 21 days, we don't recommend that they do testing. We don't recommend that they do treatment. We know that both happen. They do test, they do treat, but it's not recommended because the person no longer is infectious. PCR testing after 3 weeks of cough is of limited benefit. CDC also in their guidance indicates that if perchance a provider tests someone with PCR and it's positive, but they're not coughing, that test not be used to confirm a case of pertussis. So positive PCR, no cough, not a case. Then we want medical providers to administer TDAP to contacts and household members that are not up to date on immunizations. As we showed in the map, we need to increase community immunity in Kentucky for pertussis. So you're working in local health departments and working with medical providers to increase pertussis vaccination rates should be a major part of the local outbreak response. So if you're sort of at your wit's end because you got a lot of cases, you're doing a lot of investigation, that's prima facie evidence that your community immunity is low, and you need to work much more vigorously to educate people in the community about immunizations, work with the providers to administer age-appropriate pertussis-containing vaccines. So the next slides are going to be about immunizations. We'll go over them quickly because they are in your notes. There's nothing new for 2014 compared to this year about immunizations. Pertussis is a 5-dose series for children after delivery, age 2, 4, 6 months, and then a booster dose 15 to 18 months, and then another dose before starting kindergarten, 1st grade. Adults and adolescents need 1 dose of Tdap to replace the usual dose of tetanus diphtheria. And you can start that at age 10 during outbreaks. So we need to encourage medical providers, because we've had an outbreak since 2008, to be immunizing kids starting at 10. In the CDC ACIP recommended schedule, Tdap is routinely recommended for children at age 11 to 12. We can catch up adolescents on the VFC program at age 13 through 18 if they missed the 11 to 12 dose, and then adults should get a single dose. And what's important for Tdap is it can be part of wound management if people need a booster dose of tetanus-containing vaccine. Healthcare workers in hospitals and ambulatory care who have direct patient care should also have a dose of Tdap. If they've had another tetanus-containing vaccine recently, ACIP recommends that you can give Tdap regardless of the interval of the last dose of the tetanus-containing vaccine. As we said earlier, we give Tdap at age 10 in outbreaks, and unfortunately we still have no pertussis-containing vaccine for children if they're 7, 8, or 9, and they're not fully immunized. There's also a recommended cocoon strategy to administer pertussis-containing vaccines to provide what CDC is now calling a full circle of protection for newborns and infants. This involves prenatally administering TDAP to the pregnant woman. CDC is now recommending that women get Tdap with each and every pregnancy. So if they've gotten it with the last pregnancy and they're pregnant again, they need another dose. It's also recommended that if for some reason they did not get TDAP during pregnancy, that they receive Tdap in the birthing hospital before discharge from the hospital or the birthing center. We also need to vaccinate the baby. The cocooning strategy includes the baby. And then we need to vaccinate all family members and caregivers. And that includes the other parent, the grandparents, all adult household members, child care providers, healthcare professionals, and ideally, we need to start these vaccinations for family members during the first prenatal visit rather than giving them all post-delivery. There is a school immunization requirement for Tdap for sixth grade entry. Pertussis vaccine is not 100% effective, so we can immunize everybody and we're still going to have folks in the community that are susceptible. And as we described earlier, vaccination results in immunity, but the immunity wanes over 5 and certainly 10 years. There is no present booster dose of Tdap for adults. That's because we don't have the scientific data to show that we need that. I think if the evidence for big TDAP is going to transfer over to Tdap, that we're going to need a booster dose of Tdap. Whether it's in 5 years or 10 years, it'll be coming, I think. We just don't have the present science to recommend it. So in outbreaks, we need to remind providers that you can give Tdap without any minimum interval since the last dose of a tetanus-containing vaccine. This goes for adults too. There's only one brand of Tdap licensed for children as young as 10 years of age. That's the Boostrix brand. And then we give pregnant women Tdap with every pregnancy after 20 weeks gestation or in the postpartum period if they didn't get it. We know y'all are still fighting the pertussis outbreak in Kentucky. It takes a community of effort to stop outbreaks. There's a lot of folks that y'all work with, and we appreciate your efforts. I want to acknowledge everyone on this list who has been involved with developing, previous versions of these slides, or Christy Royalty and Liz Russell started the first version of our guidelines, and we certainly need to acknowledge their effort. But I also want to acknowledge all the work that's been done by regional epidemiologists and local health department, communicable disease nurses, and you're working with community providers about diagnosing, treating, and reporting these diseases, and with hospitals about cocooning strategies. So there may be a lot of questions, and we got a few minutes here for questions, and Leslie Minch is going to join me to answer any questions you have. But after this morning, if you still have questions, give one of us a call. We'll be glad to go over any pertussis issues that you may have. So any questions?
Dr. Brawley, is there any reconsideration of going back to the old DTP vaccine? I mean, did it give longer protection rather than this 5 to 10 years?
Yes. The question was, are we going to go back to the DT with pertussis? And we do know that it did provide better immunity, longer lasting immunity. There was a concern, I think a valid concern, that it caused a lot of reactions. In some children, if you ever saw a child with persistent screaming, they screamed for 24 hours. And it was very disconcerting to the parents. One of my own children had that problem, and it was someone here in the audience said they had it too. It's very frightening. But it also caused a lot of fever, a lot of fairly severe local reactions, a lot of redness and swelling and pain. If we go back, it would be with a safer host cell. I don't think we'll go back to exactly what we had before. But it did work, as the study in Oregon showed.
Right. Well, with this DT or the Tdap, if you have the scientific evidence to show that a pregnant woman needs it with each pregnancy and can be as often as every 9.5 months, why isn't there enough evidence to show that as adults we need booster doses that include the pertussis part of the vaccine? What's missing?
The question is, what's missing in the story between the pregnant women who get a dose every pregnancy and the rest of us? And I think it's simply we don't have the clinical trials or the longitudinal studies. If you look in a lot of the vaccine information, they go to the major health systems, Kaiser Permanente especially, where they have an excellent electronic medical record. They can follow up everybody who not only was immunized, but also follow up people with illness. And so I'm sure we're going to see some studies in the next couple of years about the follow-up of people who've gotten Tdap and how soon have they developed illness. We know that with the capital DTaPs, that it waned within the first year. In some individuals, they developed clinical disease in a year after the 5th dose.
And last but not least, what is wrong with giving this vaccine to 7, 8, 9-year-olds? I mean, why?
So the question was for the folks,
Why are we
is why can't we do it for kids that are 7, 8, and 9? No data in terms of safety and efficacy. Do providers administer it? Possibly. It would be off-label, but we just don't have the data. So immunization is a heavily researched area. So when ACIP is not recommending something that you see a gap, it's because there are no data. And it's also, these indications have to have FDA approval. And so FDA wants even more stringent data about safety and efficacy. So we just don't have them. Questions from the field?
Hi, this is Ava from Madison County. We've had some concerns in our clinic from pregnant women. Even in the 3rd trimester, they're questioning the safety of giving the Tdap during pregnancy. And we've researched and looked at the labels of the vaccine inserts, and there is no recommendation from the manufacturer. So you use the term off-label. That's kind of how they feel that we're doing with the pregnant women. Can you address that in any way?
I'm sorry. Yes.
Any FDA-approved medication or vaccine can be used by a medical provider for an indication that is not in the package insert. That's called an off-label use. And so the pregnant woman is quite correct. It is not in the package insert, and it won't ever be in the package insert because the manufacturer has no vested interest in changing the package insert. We know this from rubella vaccine as an example. We've had an off-label indication for rubella vaccine use for a long time. So what we have to do is to educate the pregnant woman about the safety of the vaccine in its use among pregnant women, and it is safe, but also that they are high risk, both in terms of they may develop the disease, and then if they get paroxysmal coughs and they're in the last trimester, they could either have an abruption and have a medical emergency themselves, or they could lose their baby. You get hypoxic. If you've ever seen a newborn or a kid under about 2 years of age with a pertussis cough, you can just watch the PO2 drop whenever the paroxysmal cough begins. And some children have seizures from hypoxia during clinical pertussis. So it's not ever going to be there. But it's recommended as part of this cocooning strategy, and the best you can do is to try to educate them and just be frank that it's not in a package insert. It won't be, but it is perceived to be safe in terms of its present use. Pregnant women just don't have complications from the vaccine personally, and their children don't have complications. So I think that's what's important. If they get the disease, they can have complications. So it's great advice to hopefully have them agree to get it. Other questions? We need a question for Leslie.
Put me on the spot. I have a question. You referenced, Dr. Brawley, the final draft guidelines for pertussis. Is there a time frame for finalizing those guidelines and sending those out to the field, or where are we in that process?
We'll do it before January 1.
Okay. Okay, so local health department nurses and the regional FDs can look for that date then?
Yeah, I hope to have them out before January 1. I'm on call that week, so I'll be here and I'll work on those guidelines for you.
Okay. Thank you so much.
Other questions?
Well, this might be a Leslie question, but let me just make sure, because sometimes I don't have a chance to read the book from cover to cover. Is the recommendation to give the Tdap to individuals 65 and older in the core clinical guidelines? It's not, is it?
It is.
Is
It
it?
is in there, yes.
Okay.
And if one vaccine is not available, the other one has been approved to be able to give as well. The Boostrix and the Addison.
Either or can be given for individuals over 65. Okay. I mean, we do have the adult vaccine that we were able to have access to. The problem is, free is always better. I mean, we really did well with the free H1N1 vaccine and had, wonderful response. But there is, I don't know if it's a mandate or what, but we're required to charge them $10 administration fee. The vaccine's free, but the administration of the vaccine, there's a charge, and that's what is interfering with my ability to provide community protection.
Because of the statewide outbreak, Tdap is available to the local health departments from KIP, Kentucky Immunization Program. So if you're in need of Tdap at your facility, please contact Laura Harrod or myself.
But I have to have an outbreak first.
No, we're considered to
okay.
be statewide outbreak. Now, if you have a localized outbreak, yes, definitely, we want you to have it available, Johnny, on the spot. But we're considered to be statewide as well.
But I have the free vaccine, but we have to charge the administration fee.
You don't have
Don't
to.
have
We were
to.
told we had to. That's what
That
I need
doesn't
to.
come from our
We do
guidance.
not.
That guidance is not from us, so it may be from your director.
I will check that out then.
The question was, do you have to charge an administration fee for the vaccine, TDAP vaccine that comes from the immunization program free of charge? And we don't require it. Your health department may. It's permissive. Is how we look at it. If you can bill their insurance plan or Medicaid, there's going to be an expanded number of people on Medicaid after the first of the year, so some of those you may be able to bill for that administration fee. The vaccine, if we give it to you free, you can't bill for the vaccine.
Right.
So in case folks in the field did not hear, Leslie was saying that we consider the entire state of Kentucky to be in an outbreak status. If you need TDAP vaccine for adults, contact Laura Harrod or their usual staff in the immunization program. We would prefer you not put an order in for delivery before the first of the year, just because of the holiday schedule. Some of y'all are closing, and we don't want vaccine to be delivered and no one's there to receive it. We'll be glad to work with you to get vaccine shipped to your health departments. Other questions? I think we're sort of at the end, but thank you very much. Call us if you have more questions.
Thank you, Dr. Excellent. Thank you. Thank you so much, Dr. Brawley. Thank you so much, Dr. Brawley and Leslie, for that excellent presentation. Next, before we let the regional FDs go, I invited J.C. Logston to come and make an announcement about the revised Kentucky Foodborne Water and Waterborne Outbreak Investigation Manual. And welcome, J.C., to DPH. We usually have people, after you've been here at least for a week, we'll go ahead and have you get in front of the camera. J.C. is the newest member of the reportable disease section. She's an epidemiologist with the foodborne and waterborne diseases reportable disease section. And I believe you were a regional epi before you came here. Is that right, J.C.? Well, thank you. If you'll come up here. If you want to come up here, and then we'll go ahead and let you make your announcement about the manual. Thank you for coming today.
Thank you very much. I won't take very much of your time. I just wanted to let you know that Joy had sent out an email about the updated Foodborne and Waterborne Disease Investigation Manual. It is online. The web link was included in the email. If any of you did not receive it, you can email me and let me know. I am in the global. A couple of things that you may want to know is the regional EPIs did receive copies of this, so there are hard copies that have been distributed to them. Some of them may have been distributed to the counties, others have not, so don't get upset with your regional EPI. If you haven't received it yet, they will be getting those to you in the future. For those organizations who have EPI teams, each county may not actually receive a copy because you have an EPI team that's actually doing the investigation for you. Some of the main points that I think would be helpful for you if you are doing a foodborne or waterborne investigation are, there's a chapter on the steps of the investigation which guide you through how to conduct from beginning to end, including writing the outbreak report. It also covers a lot more in depth the control measures that we recommend here from the state. Some other things that would be helpful are a field guide in the appendix, which goes through all foodborne, waterborne agents that you may encounter, signs and symptoms, typical foods that may be involved in those types of outbreaks. Other things that I hope will be helpful for you are the laboratory guidelines for collection and submission of clinical specimens, but also food and water. I know oftentimes local health departments don't actually collect clinical specimens for food and waterborne outbreaks because that's not something you normally do in your daily jobs. So having those readily available for you, I think, is helpful. It has been to me when I was at the local level. A couple of other things. It has our enteric disease investigation form, which we're currently working on.
You need a tricorder. You wouldn't have to pinprick anything. You gotta go. Look at it real quick. You might not like this.
Okay, so anyway, if you have any questions about it or if you have any suggestions, please feel free to email me. I'm the chair of the Foodborne and Waterborne Illness Investigation Work Group. So any suggestions you have, I will be happy to take those.
Thank you, JC, so much, and welcome to DPH. We're glad to have you. Next, I'd like to introduce Dr. Julie McKee, who is our State Dental Director. Hi, Dr. McKee. She has an overview to provide to us on oral health programs across the state, as well as new opportunities regarding the public health registered dental hygienist. So she did send, in addition to her PowerPoint presentation, several handouts including protocols and regulations. So you should have that information, I should say, with you as a part of what I sent out to everyone on Tuesday. So at this point, I'll go ahead and Dr. McKee, your PowerPoint is pulled up here, ready to go. Joelle's got y'all ready to go. So thank you so much for coming today.
Work it through here.
Yeah, or you can do it.
I can blink my eye?
Move your arrows there if you want to. Also,
Okay.
Julie.
All right.
Thank you so much.
Thanks so much for inviting me to this event. The room clears. I usually do this to the end. And the room clears. All right. That's okay. We can do this. What I'm here talking to you all about is oral health in general and public health hygiene with specifics about it. In the oral health program, we have we're still trying to find for a place for it to officially land. For nurses still to do the fluoride varnish, the kids Smiles assessment, do the varnish, do the oral hygiene instruction, and all that takes place under that. That's still in place, still paid by Medicaid. Nothing's really changed except it's not considered core, so it's kind of flying out there. We're still trying to find a place for it to land. If you have any questions on that, please feel free to bark up and let me know. I had somebody say, oh, do you want to sit down? I said, oh, I'm going to bark and run here. What I wanted to talk to you about, let me go back to nursing. We still have not only the varnish program in place, we still have the fluoride supplement program in place. And that's much more, it's much larger than I ever thought it would be when I came to this position. With 95% of people being offered fluoridated water in any given day, you would think it wouldn't be that big, but it really is. We still have a lot of people on well water and cistern water that is still collected from the skies, that water testing needs to be done on children at least annually for their fluoride if they claim they don't have city water, okay? If they've got city water, you're wasting tax money to have it tested. When you don't have city water, mostly with wells, it needs to be tested to see what the fluoride level is and make the appropriate supplementation. If you want more information on that, just give me a ring, but it's pretty easily spelled out. What I wanted to talk about is I wanted to talk about how public health departments have the option to have public health hygienists as part of their healthcare team. This is brand spanking new. This actually came about in the Revised Dental Practice Act of 2010. It's taken us this long to do the Practice Act, get it implemented, get the regulations done, get them implemented, and now we're finalizing protocols. The protocols that will be regulating what a hygienist does is, honestly, they are parallel to Kentucky Public Health Nursing Protocol. Part of it's because I'm lazy, but most of it is because public health in Kentucky has such an incredibly successful track record. And when I say successful, we are impactful to patients and we keep ourselves out of court to do that. It's been successful that I took that along with standard hygiene practices to make a stack of protocols. I did not bring the protocols here today because they're literally a stack this thick. Joy Hoskins can attest to that. But what I do have is a list of the protocols that I just wanted to just gently review with you all what the title is and why they exist. And you can see on there we've got the nurse-based oral health still on here as the supplement in the varnish program. You have any questions, you need training, you let me know. I'm the only Julie McKee on the global so far. But when you jump down to oral health that is specific to our registered public health hygienists, which are going to be certified as public health dental hygienists, they get a special license for this. There are certain things you have to have a checkoff list with the Board of Dentistry. You have to have experience. You have to, of course, be licensed. You have to have medical emergencies, all those things, and that's spelled out in the Dental Practice Act. But anyway, on the protocols, we're going to have consent for services. This is important as nurses for you all to understand the consent for services. The consent for services that is a blanket consent that health departments do with their patients and or patients through school systems for whatever needs to be done, just do. Love and kisses, mommy. That does not work for dental. By statute and by regulation, dental has to have specific and separate consent forms. They say specific things according to what the law wants them to. They say it's not only consent, it's also things like we want you to know that this is being done by a public health hygienist and not a dentist. Heck, a dentist isn't even on site. Well, it's not going to say exactly that way, but it provides that a dentist is not on site, that is done through strict protocol, that is signed and accepted by the governing board of dentistry, that they can do that. This is what we do in nursing. This is what we do in nursing. That was the parallel. So when I started talking to boards of health going, how is this going to happen? I say, this is what you do in nursing. And you go, oh, okay, that's fine, we'll do it. So, but it says things like that. It also is unique in the fact, and this goes back to what the private dentist wanted, is we ask, do they already have a dentist currently on record? Here's the deal. We hear it all the time in public health nursing too. You're stealing my patients. You're stealing my patients. We don't want to steal anybody's patients. We want to reach out, and there's enough inventory out there. We want to reach out to those children or others that are unserved or underserved to do that. So, and then I think part of the consent as we move along, but in addition to it, will be a specific health history. Now, the reason we do a specific health history, because you're going, aren't you just cleaning their teeth? Well, yes, we are. But the specific health history goes back to a regulation and statute that the public health hygienist can only see certain types of health status. And if you go back to your training, they're called ASA classifications. ASA classification 1 and classification 2 are the only types of patients that a public health hygienist can see. Now, what is that? Well, if you dig back, ASA stands for something like the American Society for Anesthesiologists, or anesthesia. That's what it is. And there are classifications from 1 to 7, and 7 is you're dead. But 1 and 2 are the ones that we can see, and basically what that means is that classification 1 is you are healthy as a horse. Nothing's going wrong. You are fit as a fiddle. Class 2 is where most of us fall in. We have some type of mild chronic disease that is completely controlled and does not really impact the activities of our daily life. And when we talk about children, we're talking about children that have controlled diabetes, have controlled asthma. That's the big ones we're talking about. We do not, nor can we by law, treat those unmanaged children. We don't want to. That needs to be more in medical care. Get them under control, then we can see them. So that's what the consent is. So you don't have a blanket. Dental is separate. Health history and dental assessment instructions is we're waiting on the electronic health records to see exactly how that's going to fit in to actually what you do relative to dental assessment. Dental assessment isn't just drawing the teeth and what fillings you see. It's also talking about how the patient takes care of teeth, other things as far as dental relationships of upper arch to lower arch, all that stuff. So it's just not counting teeth. The documentation of dental services, including the history, how you document it, that's part of our protocol. Medical emergencies in the public health setting. This is one thing that really got our private dentists, because private dentists were convinced that public health hygienists were going to kill people. And what it is there are very few medical emergencies that occur in a public health clinical setting. Thank goodness. But they do happen, and they wanted us to address those in the public health dental setting, and we could do that. First off, it is a requirement that every hygienist has to take a medical emergencies course every other year on dental emergencies that happen, or medical emergencies that happen in a dental setting, dental emergencies that happen in a dental setting. Talking to public health hygienists, the number one medical emergency that happens in a public health dental setting is, what do you think? Puke. Kids get nervous, they get upset, they barf over everybody. We know what to do with that. We've done that before. The second most common one, and is much lower than people vomiting, is people fainting. They get nervous, they get upset, they just black out. They know how to take care of that. That's not a big deal. Dental emergencies that we need to worry about are things that fall down the throat to do that. Hygienists know how to do that. They come experienced. They know how to do that. Follow-up activities. This was important to our private dentists as we develop the laws. Like, well, what if you find some? What do you do? I said, we are public health. We know exactly what to do. We know how to refer to the communities. We know how to work a case to make sure that a child or a patient gets the care they need. I said, we do it with abnormal PAPs. We do it with mammograms. We do it with TB. We are so used to doing that. Well, do you know what a tickler system is? Oh, please. But, so they want all that. That's fine. I'm going, that is fine. We do that anyway. That's not a problem. And they're like, really? It was a great learning experience for dentists to understand what public health does. And let me tell you this is just funnier, and I'll get out. One of the guys on the board is not a Medicaid provider, and because of his specialty, does not see anybody who doesn't have a wad of money. He's on the board. So he's looking at this and he's thinking all this and how are we going to get paid? And I told him the paying mechanisms, how that was going to be sustainable. And he's going, wait a minute. Health departments. I thought the health departments were kind of like the Red Cross, that the frontline workers were all volunteer and the big executives were paid, of course. And instead of getting mad, I'm going, teaching moment. Instruction for authorization of release of information, that's the same as nursing, because we're going to be interacting not only with dentists, but in some cases, unfortunately, because of the severity of the child, we'll be also interacting with a physician as well. Telephone and verbal orders, that's paralleled with what you all do as nurses. They'll be doing it the same way to write down everything you say. Fluoride supplement protocols, the same for them as it is for nurses. The fluoride bonus protocol, same for them as it is for nurses. The school health expectations of a public health dental hygiene program, this is probably going to go into the administrative part of the reference. It's talking about what to expect, how you interact, how you're part of the health team, how you're part of the education team, all that warm and fuzzy stuff that we need to embrace, and nurses do very well. Then we start talking about forms. We've got the health history and dental assessment. That is TBA, pending what we decide as far as electronic health records. We've got in there is just a sample charting. What hygienists will do, and you all know this, but just hear me out, they will be doing oral assessments, not screenings, assessments. And the way dentistry looks at the difference between screening and assessments is a screening is when a health provider who is trained looks at the mouth going, oh man, what a mess, and that's it. Or I see no possible problems. That's a screening. The assessment, and that's what these public health hygienists are going to do, is seeing the mouth, writing down every tooth and what it looks like. You know, existing fillings, a crown, it's already gone. They've lost it last week because of natural exfoliation of the teeth. It is a mouth-by-mouth, tooth-by-tooth record of it. Public health hygienists will not be doing radiographs. That is a whole nother can of worms. We can talk about that if you want to, but they will not be doing radiographs. Now, individual health departments who want to do radiographs can do their own protocol. Submit it to us, we'll bless it, they enact it to do that. So, I've got those, I really want to hear your questions because what I'm hearing, I've spoken to the public health directors, and here I am speaking to you all, and I like questions because I don't know what you don't know, and I don't want to bore you, but I also don't want to give you information going, oh, God, won't she shut up? So, do you want? Yeah, we can go through the overview. It's going to be, let's just do this real quick. This is just a review, and honestly, if you've heard me speak before, the PowerPoints are much more for me than they are for you. What is a public health registered hygienist? They are especially licensed through the Board of Health. It happened in 2010. It happened because we need them. We are not seeing enough children. Only 41% of Medicaid children in our state got any dental service at all in 2012. Now, that sounds low, but let me make it lower. Here's what we don't know. We don't know how many of those were emergency situations, and we don't know how many of them were done through a nursing varnish program, because that's a dental service. So we don't know. Who does it involve? I'll get to that in a minute, but it involves everybody, with the nurses as the supportive balcony attendees. Do we have to do it? No. No, 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 no. Do I want every health department to do it that wants to do it? Yes, 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 yes. How's it get paid for? We're still working on that. We already have 3 of these programs in the state, and one of them gets paid by foundation money. Foundation for Health in Kentucky underwrites everything they do. Another one gets paid by local tax money. They've done that for years to do it that way. And there's another county getting ready to do it. They raised their public health tax specifically to underwrite a public health hygiene program. The third one actually gets Medicaid money by using local dentists who they bill through their number. God love them. It's working. It's working for them. I'm not sure, as public health as I am, I'm not sure I put my number on the line for that. So that's what we're trying to do. What we're trying to do, and the reason, what I've done yesterday, early this morning, this afternoon, and tomorrow, is we're talking to the MCOs, each of the MCOs, to make sure that they know that we want those preventive services as part of the preventive package, just like the immunizations, just like some other things that we do as nursing. So that's, and if we can do that, it's not a cash cow. Tell your health department director, it's not a cash cow, but it can pay for the program. The services can pay for the program. It's in law. That's part of your handout, or both of those. It's got to be part of a dental program. It's got to be part of a health department program. A hygienist who's unemployed just can't pick up and say, I'm a public health dental hygienist, and that they've already started trying to do that, and they can't do it. It's illegal. They practice within their scope of practice that is defined by the Dental Practice Act and also through the protocols of the department and of your board. All this has been blessed, sometimes grudgingly so, by the Board of Dentistry. The protocols have to be approved by the individual boards of health. Not every health department is going to do this. They need to know what's up. They'll be working with their dentist member in order to get that done. They have to be certified by the Board of Dentistry as a public health hygienist. They come with experience. I talked about that. Relicensure, this is interesting. Relicensure has to include 5 hours of public health. It doesn't have to be public health dental. It can be epidemiology, emergency response, those things, because we may be a nurse, I may be a dentist, we may have hygienists or whatever, but we're all public health professionals, and we need to know what that responsibility is. They can work in various locations. They cannot work in a private dentist office. That's private health, not public health. They can only provide primary preventive services. My rule of thumb, which is broken all the time, but my rule of thumb is don't make them bleed. This is not where you go to the hygienist and they pick on your teeth for 3 hours and make you bleed like a cow. Okay, this is primary prevention. That's secondary, tertiary prevention. We can talk about that later. We talked about the ASA Class 1 and Class 2. We talked about the informed consent, why it was separate, and why it has to be separate. It's by law. This program will also never prevent a dentist from being part of a dental program. We've got one health department, they want the hygiene, but they're also looking to set up a dentist in their health department to meet those needs that would be paid by local tax money. What they can't do, they can't work without the health department. Can't be done. It's illegal. The board will sniff you out. They can't work without the Board of Health making formal adoption. This is not a unilateral decision of the public health director. They can't see patients that are beyond the ASA classifications 1 and 2. Why? Because at this point, when you've got uncontrolled chronic disease, your dentist and your physician need to be part of your treatment plan for care, even the cleaning to do that. They can't take out teeth, not even the loose teeth. They can't fill teeth, not even with the drugstore goo, the Dentim that you mix up and stick out. You can't do it. I've reviewed this. I've reviewed that. We're waiting for the protocols to be finalized. They're at a very high level, and nobody's picked out a piece of paper going, what is this? So I think it's going well. This is not a standalone program. You have to have what I call the trinity of success. This is very important. You have to have your Board of Health. They have to approve the protocols. They have to approve the hiring process. They have to decide on a sustainability plan. The school system or other partner site, you have to have a willing school system in order to do this, because school systems, as you know, they're kind of a low-hanging fruit. There are a lot of kids out there that need our help relative to dental preventive services. Some school systems, they may want you like crazy, but they've got the edict from their Board of Health. They don't do anything except teach during the whole school system. That's all they do. No extra programs go in. You've got to respect that, even though the need may be huge. You've got to have community dentists. That's one of the things is I remember when I was at Wedco, we had the the breast and cervical cancer program, that we could find all sorts of disease, and then it was like, well, got a really nasty pap. Sorry about your luck. But we have to have a place to be able to send these. Every health department, not Julie, every health department's got to work with their community dentist to find the dentist that they can pitch the patients to. Okay, and we do that for our other services too. So every health department will have their own list in their market of where they can send those kids. You have to be able to consider the Medicaid and the no pays. That's what we do. The Board of Health, the schools, the community dentist. You've got to have all these three. Let go of any one of these. This is not going to work. All right, you don't have to do it, but you've got to, if you want to do it, you've got to think it through, and that's one thing that we're getting ready to do. Went through this, went through that. Ask you all not to bleed. I'm asking the public health directors to bleed. What I'm doing is, I'm going to pick on Franklin County, just because we're here. One thing that you may do, let's just pretend that Paula has enough interest and enough school contacts and contracts that she can, she knows she can keep 3 hygienists busy, but she's not for sure about that 4th one. She can keep part-time busy, whatever. She will be asked to bleed to a contiguous county, say Anderson County, that's where I'm from, to bleed in that county and work with them to see if they can fill up the rest of their available time through services in Anderson County. So we're asking the hygienists not to bleed. We're asking the public health directors to bleed. I know that it's done a lot. I'm asking you to continue thinking about doing it when you are working with the public health dental hygiene program. There is a document that your public health director has called a FATBAC, and it's in lieu of frequently asked questions, but this is new, so they're not frequently asked. So it stands for something like future anticipated to be asked questions, something like that. So I'm glad you're all laughing, because I have somebody here, the department's going. All right. The next steps. We need to formalize the protocols. We need to find them a home. It is not core, but it's like core point 2 or something. 3 types of training. Train the health department administrators. The little infomercial I did at CADA is not enough. This is going to take a long time for them to understand the detail of it. Train the boards of health. You invite me to your board of health. I will explain the good, the bad, and the ugly, and the responsibilities of the board of health for these, because they have a big responsibility in this. The hygienist. We'll work with them. When I say I'm going to train the dental hygienist, I am not going to train them on how to count teeth, what a distal lesion is. They already know that. They've been doing that for years. What I'm going to train them to do is how to be a public health member, how we do forms, why we do so many forms, and how to be part of the public health member team, parts of reporting, the standardization, things like that. So that's what we'll be training them to do. Funding. Woo-hoo. There's so much more to this, and I can talk about it all day, and I have, and I'm excited about it. It's got great potential. The potentials are that we can, and let me just talk about children. Unserved children, little kids in pain cannot learn. And 80% of our poor kids carry, 20% of our population, our poor kids carry 80% of the dental problem. So we've got some inventory to look at. It helps them learn, and y'all have heard me say this, that when people can learn earlier, they learn more, and when they learn more, they learn longer, and when they learn longer, they stay in school longer, and when they stay in school longer, they get a better job, and when they get a better job, they can pay more taxes, and that means we can all pay less tax, because taxation is a shared burden. So there is an economic standard to this program. I don't think I've made a leap for that. You can find all sorts of studies about that. This is just, and what's in it for you? A new program that is sustainable. is financially sustainable, but you've got to have that trinity of success in order to do so. So this is just an infomercial for you all. You let me know any questions you might have.
Are there any questions from the group out in the field? Are there any questions for Dr. McKee?
This is a first.
So Dr. McKee, I have a question.
I've bored them to death.
If the local health department is interested in those discussions, should they contact you directly? Is that what you would like
Yes,
to do?
that's the first part of it. If you're interested, your public health director is interested. I've had dentist board members contact me directly that are interested. Contact me directly. We can come up with a plan on how to implement it because everybody's going to look different. Everybody's going to look different. Like I said, we already have 3 in place. There are about 3 more chomping at the bit to get ready to do this. They're ready to go. And I would say that our big goal is to use the next 6 months for planning, training, buying equipment, working with schools ramp up, so that just like, and I've been a public health director, it's like we start July 1st or we don't start at all, you know. And so that's kind of our goal, is to have everything in place to make it as easy, because it's going to be hard anyway, to have health departments ready to go if they want to be by July 1st.
Julie,
Yes.
this is Alicia Combs in Montgomery County.
A long time no hear.
I know. Did you say that it is reimbursable through Medicaid right now for dental hygienists?
No, that's what I'm working on, and that's what I've been saying. I've worn out 2 rosaries over trying to get God to get this happening. But no, I'm working with the medical MCOs for them to deem it part of a preventive package. The need is so great that everybody I've talked to, they're not like, we're not doing that. They're like, I understand the need. We need to work on how we're gonna work it into the payment system. So we're not getting a no. We're getting a very good, we need to work on this. So, Dr. White, don't you feel that way about yesterday and today? Yeah. So, so I am hopeful. I know I'm a Pollyanna about it, but if I can't be, who can be? So we're working on that. Let me give you a little, and I can send more to your other people, and people have this. If you were to have Medicaid reimbursement, that you would have to have between 50 and 60%, and why that difference is, I can answer another time. 50 and 60% of your kids or your patient pool being paid by Medicaid in order for you to pay for your program. And when I say pay for your program, I mean to pay the salary of your hygienist, to pay the salary of accompanying assistant, to pay all the fringe, all the benefits, all the other direct, all the indirect, the retirement, to pay for, to stock your dental unit for the next year, to do that. All that would be paid for. Now, it's going to take an assertive dental team to do that, but we've got 3 assertive dental teams already out in the state that do that every day, and they can teach us how to do it. So the answer is no, not yet.
Will there be any funding for purchasing equipment to get started?
That I don't know. That I don't know. So the answer is no. But you can, it would be a one-time investment of your health department to make an investment of $61,000 to get the dental equipment, the dental supplies, the van or truck to take it all. And when I say dental equipment, that's enough for 2 treatment areas to do that. And the biggest part of that is honestly, is the vehicle to drag it all. It's portable equipment to take from site to site to do that. So if you've got a vehicle that will take boxes and crates and all on rollers already sitting in your parking lot with not a whole lot to do, you may have already cut your potential investment in dental equipment in half.
Other questions from the field?
I appreciate it. You know how to reach me? I hope you do it. Thank you all.
Thank you, Dr. McKee, and I'm sure we'll invite you again
As time goes on.
Yes, okay.
All right.
We'll be in touch, and thank you for today's infomercial. Next, we have the Emergency Department Superutilization Project, an overview of this new initiative that's going on at the cabinet level with numerous departments within our cabinet, as well as with hospitals across the state and, of course, local health departments. I invited Dr. White to come, who is our Deputy Commissioner for Clinical Affairs, as well as Brandon Hurley from the Center for Performance Management, who's the point of contact, Brandon's point of contact for this project, to provide you all with an update and an overview of this initiative and how local health departments, if you're not already involved, can perhaps become involved, and just for an update purpose. So Dr. White had sent about 5 slides there. She said we didn't necessarily need to print them out for today, but she's going to have those. She's going to review those with you all this morning. And then Brandon, we did send the 2-pager of just a synopsis of the project for your all's information, so you can share with others. Thank you, Dr. White.
Thanks, Joy. Good morning. This is a very important project to me because in the process of writing a grant, I put on 10 pounds of grant weight, writing 10 pounds of grant ice cream. My husband, when I finally finished off the cookie dough ice cream, I came back the next day and he had bought me a new half-gallon, and I said, "Why did you do that for?" He said, "I was afraid that you might come home and there wouldn't be ice cream here, and I didn't know what would happen." So I feel a little bit disingenuous doing this because Brandon is actually the person that's done all the work. So I will just kind of give you an overview of part of this to talk about what we're calling ER SMART, Supportive, Multidisciplinary, Alternatives, and Responsible Treatment. I would love to take credit for that, but actually Dr. Langfeld came up with that. And for the people that know Dr. Langfeld, the medical director of Medicaid Services, he's kind of a button-down kind of guy. So I was really impressed that he came up one night with this really kind of clever thing, because it truly, acronyms sometimes are just something that you tried to make up just because you had to have one. This really does cover what this is about. I mean, we're looking at supportive, lots of wraparound services, alternative ways to look at this so patients can get responsible treatment. And this all came out of, and I know y'all hang on every legislative piece that is passed in the legislature, but there was something called a prompt pay bill that was passed in the legislature last year. House Bill 5 is what it was called, and the governor chose to veto that. But when he vetoed that, he also came up with about 5 things he felt like, and I don't want to get all politically wonky on you, but he felt like it didn't really do what they intended for it to do, so he vetoed it, but came up with 5 things that he was going to have done in order to fix the problems that the legislature was interested in addressing. And one of them was to say, right now people are using ERs as their primary care office. And y'all know that, and y'all see those folks all the time. They're not just in health departments, they're in every walk of life. People that just don't want to, we had people when I was at Frankfurt Hospital, they would go to their doctor's office and if there was a long wait, they would go to the ER because they thought, and then they would wait, and if it got pretty close to time that they were going to be at the doctor's office, they'd leave the ER and go there. So people don't understand that utilizing an ER is inappropriate. It delays people that really need to have care getting seen. It's gigundally expensive, and there are better ways to do this. So Dr. Mayfield at the time, this is before Dr. Langfeld got here, was tasked to do something about this. Dr. Mayfield, when she was at the VA in Louisville, was also tasked with a similar responsibility. They were having lots of veterans that were showing up at the VA ER. And they said, we got to do something about that. So she was able to arrange for about 3 or 4 clinics were set up across the city of Louisville, so these folks could be seen in their area in a timely manner. And so they really cut down their ER utilization so it's something she's had some experience with. So she got the program started, and then about a month later, Dr. Langfeld, who's a family practice doc, he practiced in Louisa for a while. He likes to say he did home visits and deliveries, so he's been on the front line trenches, and so he came as the medical director for Medicaid Services, and so now they're doing this program together. this is the reason that this is kind of important. This is looking at 1 year's data. There were 193,000 plus ER visits. This is the frequency distribution, and again, that gets all kind of statistical, and I took statistics twice and barely passed it both times in graduate school, medical school, and was glad I'd never to do it again. 45,000 people went to the ER 4 times in a year. Now, I've been to the ER in my lifetime, but 4 times a year, I've never done that. I've never had a need. I'm fortunate and blessed enough not to have a medical reason that I could even think about going that frequently. 4,000 went 10 times or more. And then there were the really hardcore ER users, 2 of them that had 121 ER visits in a year. You know, that person is saying, would someone please help me? I cannot handle this. I cannot handle what's going on in my life. And this is how I'm trying to fix it. In Kentucky, yes, this is only Kentucky data. This is only Kentucky data. One of them went to 30 different ERs. All right, I had a patient. She was 20 years old. She weighed 350 pounds. She was virginal, and she had endometriosis because I took out an ovary because she had an ovary about the size of my head that was a big endometrioma, and it was torn and it was causing her pain. So every time she hurt, and she was a little challenged, so every time she would hurt, she would cry, and her mother would get scared that her other ovary was doing the same thing. So her mother would take her to the Harrodsburg ER, and they would see her. Well, you cannot examine this woman. I mean, it's impossible. Even if you did, you still wouldn't know what you were feeling. So they would do a CAT scan to be sure her ovary was okay. They would give her a couple of Lortab and say, call Dr. White the next day. And then the next day, they wouldn't call me. She would take a Lortab. She didn't like the way it made her feel. So that night, she would be crying again. So her mother would take her to the Frankfurt ER. And they would do a CAT scan because they couldn't examine her. And they know I'd said we did a CAT scan yesterday. And then same scenario. Then the next night, they're at the UK ER getting another CAT scan. So these are the kind of folks that need help, and it is not multiple ER visits. So one patient actually went to 30 different emergency rooms. Some of this is drug seeking, we understand that, but not all of it is. A lot of it is just, I can't handle this. And there are some mental health issues, which is one of the reasons they can't handle it, and they just need more help. So what Dr. Mayfield, Dr. Langfeld did was about the same time, the National Governors Association put out, and again, Brandon wrote this proposal, to get some technical assistance. The Policy Academy for the National Governors Association, we're going to do a project on superutilizers. It just happened at the same time. It was like the aligning of the stars. And so Brandon wrote this beautiful proposal, and we were able to get that recognition. Doesn't come with any money. You know how that is. It's like, oh, you're doing such a great job, and that's what you get. But it has provided us with a lot of great technical assistance with their academy. And so it's helping us as we expand this program. And I also like the logo. I thought that was pretty cool. So then we were tasked with the Centers for Medicaid and Medicare Services have these innovation grants. We applied for one for a diabetes prevention program a year and a half ago. We're not accepted for that, but we decided to write a superutilization grant. And so that's where I got the 10 pounds. And so Brandon and Emily Parento in the Office of Health Policy and Dr. Langfeld and just a whole host of people in this building, we wrote a $24 million grant to try to help us with putting this statewide as a proposal to try to increase wraparound services. And what we did was we came up with I hope this is the latest one. I glanced at it. I don't think I left anything out. But we would see that there would be a connection between the emergency room hospital and the local health department, because we feel like you are the conveners of care in most of your communities. I mean, you know the people that are going to the ER 30 times. You know their families. You know their sister. You know their history. And so what we were going to try to do is present the health department, because when you do the map, when you do your egg chart, you are touching all those services. So it's not just a mental health services, but it's transportation, it's housing, it's juvenile justice, it's a whole host of places. And I think this, this diagram is in your handout that Joy did send out, the little bubble diagram. I was just excited I could figure out how to do that on the computer. But so what we did was the the group, and I don't know how these 16 places were figured out. I know about them. These are 16 different hospitals that are in the phase 1 group of this superutilization plan. So these are hospitals around the state. The first thing they had to do was have a lot of ER utilization, and the second thing was they had to be connected to KHI. Because in order us to follow this, to collect the data, to be able to know what's going on, we had to have that ability to be able, for the health department, to check into KHI and be able to say, oh, the hospital would say Mary Rogers was in the ER last night. Okay, I'm at the health department. I can look that up and I can say, okay, this is what they did with Mary, and let's contact her and let's see what we need to do for some kind of a treatment plan. So it's not that the health department will do things. They will know who to contact to get Mary into whatever system she might need. And a coordination with the primary care doctor, the medical home, if she has one. If she doesn't, help her get connected to a medical home. So that is the person that will be driving the care model. And we're the ones that are, and right now, I mean, y'all probably have that phone list right by the telephone when somebody calls. Who do you call for transportation? You already know that. You already know all of those kinds of things anyway. But this will formalize it so that you will be recognized. So we're selling this to these first 16 hospitals, and I didn't put it in because I know y'all know what the egg chart is. And so we presented that, and I threw that egg chart up on the wall and showed the hospitals what you already do and what your abilities are. And they all just stepped back and said, this does not need to be a hospital-directed outreach. The health departments are the people that already know how to do this. So if we get this grant, which we will know the end of January, haven't heard a no, that's good, then it will provide us to do some intensive training with these 16 sites, with their leaders. The first thing I put into the grant was we're going to do team building, because we've got to get everybody on the same page that what a wonderful thing this is going to be for these patients, to actually be able to not come to the ER and just get one medical thing treated, but to get, they'll have to sign a consent that says, yes, we want to be involved. It'll involve families. It'll involve community care workers. It'll involve a whole host of things. And then we're going to do it with these 16 hospitals the first year, because we want to get our act together with 16 places. Then after that, we will have a phase 2, a phase 3, where we'll bring in, and our ultimate plan is over 3 years to get all the acute access care hospitals in the state involved in this superutilization group, and bring in their health departments as the coordinator, the convener of care for those patients. It's what you're already doing, but it gives you that recognition and that authority to do it. Hospitals are going to be reaching out to their health departments more and more, because over time they're going to start getting, they're going to get less payment if people get readmitted to the hospital within 30 days. I mean, they want these people to have some kind of a plan, and somebody, as the colon cancer video that y'all may not have seen, but this woman said, I don't think anybody cares about me, but Shirley does. I went in the health department, and Shirley told me about this colon screening program, and I think Shirley cares about me. And I'm sure, I don't know Shirley, I'd like to meet her, but I'm sure she does. And this woman felt that connection. And so this is how we're going to help people get better. We'll always have people super utilizing. There'll always be people we can't get to, but there's a whole bunch of people that with very little, as opposed to an ER visit or an ICU visit, with some monitoring of people's diabetes. I mean, y'all know all the different things, that if we just did a few other extra things, these people's lives, quality of lives, would be so much better. So I didn't want to give you lots of real big details. I think this two-pager that Brandon put together is a wonderful summary of what's going on and what our goals are. Our goals are to try to find some funding for this, some extra funding to make sure, like I said, you're already doing it, but let's do it a little bit more formally. Let's get y'all the training that you need. Let's get this better coordinated so that it's something that can serve our patients. Brandon, have I missed? What have I missed? I'm sure I've missed a whole bunch of things.
No. The only thing that I would add is the 16 sites were originally identified
in part because of their involvement in KHI. So, we can't track super users if you don't have the data. So those hospital sites are already actively sharing with the Kentucky Health Information Exchange. So they're pushing and pulling information from that. I think the two-pager, it has a lot of information on it, but it's very condensed compared to some of the stuff that we have on this project. So I hope you take a little time to look over it. I think it is something that's, it's going to expand, and there's real cost savings there, and there's real value there. And the hope is that there's, new funding and new mechanisms for health departments there, because I know you're already doing some of that navigation for people, not because anyone's paying you to do it, but because people are showing up and there's a need. And that's what health departments do. They feel that need and they help that person out. So this is a way to meet that. I'll also let you know that there's another document that we didn't share, which is another kind of overwhelming if you're not involved in the 16 initial sites. But if you are one of those sites and you are not aware of what's going on, there's a document that has an update by a hospital. So I'd be happy to share that with you so that you could see, for example, what's happening at Harrison Memorial Hospital in regards to this project. Of course, there's some barriers and some obstacles, and we're working through some of those, and it takes a little time, especially since there's not always identified money, especially for health departments to participate in the project. But it has good value for patients and the system as a whole.
And we're hoping that we can reach out to the hospitals, because this is going to save them money. We already have some of our health departments that are embedding some of their health department staff in a hospital as these people are discharged. Because pretty basically, when you break your hip, you lay there in the hospital and say, I want to go home, I want to go home. And so they tell you, you can go home today. And you're like, I'm going home. And the discharge planner comes in and says, let's talk about your discharge planning. And the patient says, I'm going home. And they say, well, you need to do this and this. Well, I'm going home. And they get home and say, did somebody ever talk to me about what I'm supposed to do when I get home? Because they're in the moment. So having a follow-up of somebody saying, okay, now, get that piece of paper out of your folder. Let's go over that now that you're home and figure out what do you need and what you don't even realize that you need that's available out there. That always stunned me. I mean, my father had congestive heart failure and renal failure, and my mother, who was 80, couldn't get him to the doctor's office. Well, for $3, some van came and took him to the doctor's office and brought him home. And we didn't know that. So I think of how many years that were taken off my mother's life trying to get my father's wheelchair out to the car, get him into the car, get him into the doctor's office. It was huge. $3, we didn't know that. So we didn't ask. I didn't even think to ask. So once I asked, one of the nurses said, well, don't you have that in your community? I don't know. So those are the kinds of things that make a huge difference in people's lives. You already know that. We're just trying to make that a little bit more formal so it will make it easier for the patients. And since it will save the hospital money, we are from the get-go telling them, this is something you need to put some skin in this game, because this is going to make people's lives better, but it is going to be, in the long run, helpful for your hospital. So we're going at every angle we can find a nickel to push y'all's direction.
It's also a responsibility of the MCOs. I mean, in our contracts with the MCOs as a state, there's quality improvement. You need to show cost savings in certain areas. Well, ER use is one of the most expensive areas for that. So if we can require some of these measures and show this, you can pay for this for $300, or you can pay for this over here for $3,000. Which one do you want to pick? You just saved yourself a bunch of money. We need time to collect all those pieces and iron out all those details as we move forward. So I'm happy to answer any questions if you want to call and talk about it, or email. I'd be happy to do either.
I know that's pretty quick and dirty, but I didn't want to get into too many of the weeds and the mission and vision statement, and Joy knows how I am about that stuff. It's like, let's just do good stuff for people. But I know you have to collect data too. Let's do good stuff for people and collect data. But it's been very well thought out, but it's still way early in the process. So we like your input. We want to know what maybe you're already doing that we may have not even included in here. So we can be sure that everybody knows the whole menu of things that might be available in your community.
And so if the local health department nurse has questions, they can contact Brandon?
Yes.
Is that correct?
Fine with me.
He answers his emails faster than I do. So.
I will answer you, I promise. If you call or email. It might take a day or two, but I will answer you.
Are there any questions from the room or from the field?
Rebel?
Do you know when you'll hear back from the grant?
The grant is we're supposed to know something January the 15th. I'm telling everybody the end of January because so many of our CDC things have been delayed a month because of the month shutdown. And so everything's delayed. So I'm telling myself end of January just so I don't hyperventilate too terribly much. But it'll be then, around then.
With or without the grant,
We're
you know, the initiative is still there for the governor. It's still a priority. It's still a huge cost to the system as a whole. So it's still going to move forward. You know, so with or without the funding, we're going to move forward with the project. We just have to figure out how we're going to fund it and sustain it as we do that.
Which is why we're encouraging the hospitals to look at this and make sure everybody, you know, is bringing something to the table. I mean, y'all are bringing your expertise. How's it helping you? And if it's helping you, then what are you going to do to bring that expertise to your patients in your community? So we're really working on that. Questions out in Cyberland? Okay. Thank y'all very, very much.
Thank you, Brandon and Dr. White.
Thanks.
Special thanks to Dr. White. She had about three different commitments for the same time slot. So appreciate your time and providing this information to the nurse leaders, both of you. Next, we have an update on the electronic health record status report. Jacqueline Lee, unfortunately, called in. She's ill this morning, so I picked up the phone and called my new best friend, Kathy Fry, who, for those of y'all who may not have met Kathy yet, she was previously the CIO of the County for Health and Family Services. Now she is back as a vendor under the name of the entity of SDG Blue. Did I say that right? Yes. Okay, great. And they are a vendor with the County for Health and Family Services, specifically with the Department for Public Health. They have two main initiatives as a part of their contract deliverables. One is the identification and the assistance with the implementation of the electronic health record for local health departments and DPH, and that's the part that she's going to be talking about specifically today. But then the second part of their deliverables, their contractual deliverables, includes DPH IT assessment. And so those two components are kind of intertwined. We're going to be, the Division of Women's Health is actually going to start those meetings with Kathy and her team this afternoon. So it's timely that you're here. But Kathy presented an overview update to the local health department directors on Tuesday at the CADA meeting. So I asked her if she would be so kind, and she said yes to come and provide us a Reader's Digest condensed version of that same presentation that she gave on Tuesday. We've got you all loaded up and ready to go here, Kathy. Yeah, yep, we got it all ready. Thank you so much for coming and pinch hitting for Jacqueline. I so appreciate it. Kathy's great to work with, and so is she, and so is her team. So at this point, I'll turn it over to you, Kathy, and we've got an extra 5 minutes from the previous presentation, so we've got about 20 minutes.
All
Okay.
right.
Thank you again.
So I assume everyone can see the screen? Okay. How do I switch it over? Yeah, okay. Very good. Thank you, Joellen.
And the camera's right over there, Kathy.
Okay. So thanks for agreeing to let me speak here on behalf of Jacqueline. And as Joyce said, I gave a presentation to the CADA meeting, and so this is a presentation with an extra slide at the end, so you can kind of have an update as what the outcome of that meeting was. So my firm, we work through SDG Blue. I'm with Health Tech Solutions. We were hired to gather and finalize high-level specifications for an electronic health record that can be used throughout the local health departments. We were to conduct independent reviews and analysis and determine if EHR that we were looking at met the functionality that was needed within the local health departments, and including a cost comparison for the different products. So our tasks were, we had to ensure it was the most practical and economical choice. We identified risks and issues. We did our basic project management tasks that we do, and the main point there is bullet 3, where we conducted independent reviews and analysis. And a priority was given to those EHRs that were already connected to KHI, and those that were maybe not connected but were in the public health space. There's a lot of EHR vendors out there. It was a priority for Dr. Mayfield and the Department for Public Health to access the information that's already available in KHI. They gave a presentation at the CADA meeting. They have hundreds of providers that are currently connected. They are getting Medicaid claims data. So a priority was given to those EHRs that are already implemented with KHI and pulling that information into their EHRs. So we actually began the project the second week in October. We planned for a decision in December. Initially, we involved the CADA president, and we involved 2 other health directors. We worked closely with Joy, and I know a number of you all were able to participate in the webinars and the demonstrations that we had. For those that haven't, we have another opportunity for you to get involved that I'll talk about here in a second. So we initially contacted 9 EHR vendors, and they were Athena Health, Cerner, Easy EMRX, which CDP brought to the table, NetSmart, Patagonia Health, Success EHS, Allric Medical Systems, VersaSuite, and Vital Health. So 2 of them were eliminated due to either a lack of response on their behalf or that their requirements didn't really match up to what was needed. So we had demonstrations with 7 of those vendors, and they were Athena Health, Cerner, Easy EMRX, NetSmart, Patagonia Health, Success EHS, and Allric. I think the first 2 were Allric and Patagonia Health, and they presented at the October CADA meeting. And then the others we actually had individual demonstrations on. So I know a number of the nurses were involved in those demonstrations. So in addition to do the demonstrations, they filled out a questionnaire to see how closely they matched our requirements. They did a high-level cost analysis. And our job was to develop a short list of recommended vendors to bring to behalf of CADA and to DPH. So we took those recommendations, and we took 20 of them. We did a weight from 1 to 5 on those based off of what we heard from you all as far as what your requirements were. We verified those with the steering committee to make sure that we had the weighting right. And then we categorized them into 4 categories: clinical, technical, administrative, and business. So the clinical requirements were, did the EHR product meet meaningful use requirements? Was it currently connected to KHI? Did the vendor have existing health department experience? Did the product have the ability to track population health? Was it 2014 ONC certified? And did they have the ability to add functionality as needed? This it goes back to the need to make it agnostic. So we wanted a product that didn't only just fit your current needs, but were able to grow and expand into other areas, and if it had a dental component.
And Kathy, would you mind to briefly just define ONC?
Yeah, so ONC is the Office of the National Coordinator, and they are the agency that is in Health and Human Services at the federal level that actually sets the standards for electronic health records. So there was, previously, there was a certification that EHRs had to go through. It was the original certification. We call it the 2011 certification just because that's the year that it happened in. They have required EHRs to actually make changes to their products, particularly to meet the stage 2 meaningful use requirements, which providers will have to start in 2014. And so the 2014 ONC certified is actually the current standard for the Office of the National Coordinator. And there were probably half of the vendors had already met that certification. There were some that were anticipating on getting their approval this month or early January. And then there were a couple that actually they said it was on the horizon, but they really didn't have a date. So obviously we marked those vendors down on the scoring if they did not have a date yet.
Thank you.
You're welcome. So technology requirements were that first bullet, ability to deploy a statewide instance. What that means is that we wanted an EHR that actually could be used across all the health departments. So if a patient comes into County A in one day and next week goes to County B, that information needs to be shared amongst all of the local health departments. So we actually had a demonstration, and the product was really good, and it was public health related, but at the end we found out that they were going to deploy 61 or however many instances we needed, different EHRs. And so obviously that vendor was marked down. So that was the first bullet is what that means, ability to deploy statewide instances. We want one EHR that can be shared across all local health departments. Ability to interface, there were a lot of different interfaces that were identified, particularly with WIC and the referrals for WIC. We identified some interfaces we can do with hands. The IT folks have some initiatives going on at the cabinet level where they're doing a master patient index. So they wanted the ability for the HR to register those patients into the cabinets, what they call their master data management. So we kind of just lumped all of those into one category that was called the ability to interface. It was requested that the vendor actually host this application. So the cabinet wouldn't have to buy servers. You wouldn't have to pay someone to actually maintain those servers. And that's an option that many practices are actually taking advantage of now. And so it's something that every EHR vendor offered. So that was what the hosted by the vendor means. And then web-based is we want you to be able to access that via the internet. So we don't want you to have to actually have something that's on your desktop that you can only access from your particular PC. So that's what those requirements were. Administrative requirements, seamless throughout the department. We got that requirement from the local health directors, where that relates to they don't want to have to double key into different systems. So they want it to be as seamless as possible with the systems they currently had, and it also relates back to somewhat to the interfaces that I talked about. Most of the EHRs offer a billing component, but if they didn't, they wanted it to be interoperable with their current billing system that they have. We needed to have a full practice management system from scheduling through billing, the ability to train users statewide, and customer support 24/7. And then last but not least, we lumped these requirements under business, which were the references. So we called references for all of the HR vendors. We checked their financial stability, and business capacity relates to have they done a project as large as what we're asking for a statewide instance of electronic health record. So once we weighted those requirements, 36% of them, the majority of them fell under the clinical, the next was technology, administrative, and business. This slide is a little hard to see. We actually show the categories scores by vendors. So our recommended list, we had recommended 4 products for CADA and public health to consider. They were Success EHS, Cerner, Easy EMRX, and Athena Health. And there's some slides after this that are a little easier to see. The clinical scores here show that one vendor, Success EHS, scored highest on the clinical scores. The other 3 were pretty similar in their scoring. On technical scores, Athena Health scored a little bit higher. The other 3 were pretty much in line. Administrative category, Success EHS scored the highest, Athena scored the lowest. And then last but not least, business, Success CHS scored a little bit higher than Athena, and then followed by Cerner and Easy EMRX. But as I mentioned, we also wanted to get a cost estimate. So, you know, if this product was the greatest thing that you've ever seen, but it wasn't going to be cost effective, obviously that was something that needed to be considered. So these were high-level estimates. The premise was that after we narrowed the list down, you would see additional demos and you would work and negotiate those exact cost estimates after we narrowed the list of vendors down. But as you see, there was a significant difference between the total cost of ownership. We took the one-time cost, we then took the monthly per user cost and multiplied it by 1,200. That was an estimate that we had as far as initially what the number of users would be statewide. And so they varied from, this is over 5 years, from 5.5 million from Cerner to $46 million from Athena Health. So just to kind of relate to the differences, I think Cerner's monthly cost was $60 per month, Success CHS was $75, and Athena Health was $625. So based off of that, we presented this to CADA, and these were their total scores between the technical. We combined the technical and the cost scoring and did a kind of a 75-25, 75% technical, 25% cost, and those are the scores from the top 4 vendors. So we presented this to CADA this week, and they decided what to do was to move forward with 3 of the vendors. They decided to move forward with Success CHS, Cerner, and Easy EMRX. They are going to ask for on-site demos where those folks will actually come to Frankfurt, and you can actually see an on-site demo. They've also asked separately for a webinar, so for those folks that couldn't actually come on site, we'll do a webinar. And they decided to eliminate Athena Health based off of a couple things. One was the total cost of ownership. The other was they had also done some research and had maybe got some bad references on that particular vendor. And so they asked us to eliminate that one. Next steps, in addition to the on-site demos and the webinars, they're seeking volunteers to serve on a subcommittee that will help with the HR selection. And I know one of the things that they kept stressing was that the folks there, the end users, the nurses need to be heavily involved in that. And with that, I can take any questions anyone might have.
I have a question for you, Kathy. When the dates for the webinars are scheduled, would you mind to share that information with me, and then I'll be able to share it with not only the DPH nurses, but of course the local health department nurse leaders as well.
Absolutely.
Okay. I know we had a short turnaround time. We were really trying. We condensed that time frame where we wanted to see how the first round of webinars and presentations. So
I think we're going to give the vendors 4 hours is what we talked about for the next round. So they'll have a longer time. And we were actually going to, they're seeking what we call use cases or scenarios where there's high priorities. WIC was one of them that keeps coming to the table. So we wanted the vendors to be able to come and show us exactly the same scenarios, and so they're seeking information from the other health departments, and you all, I'm sure, could provide some input into that as to what we need to ask the vendors to come and demo. So instead of just having what we call a dog and pony show, we're going to ask them, okay, we already know about your company, we've heard about that, you're on the short list, we can skip that. Here's the scenarios we need you to show us. And so if you have any input as far as what you think would be a priority to see, you can, I think Scott Lockhart is actually collecting that information, so you can email him if you need to. I can give you my contact information, or you can send it to Joy and she'll get it to me. Any other questions?
any questions from the field?
All right. Well, thank you for letting me talk to you today.
Thank you, Kathy, for coming and pinch hitting for Jacqueline. I'm sure we'll see you again, and maybe you can come and update the nurses as it all progresses. Exactly. Next, we have a TB program update provided by Emily Anderson, TB program director. Thank you, Emily, for coming, and we'll turn it over to you.
Yeah. Thank you, Ms. Joy. Good afternoon, everyone. It's a pleasure to be here today. Been a busy morning in the TB world out there, as we've contacted several of you already. So I'm going to get started because I know everybody's hungry and wants to get out of here and go to lunch. We've had a lot of transitions in the TB team here at the state level in the last 6 to 7 months. I joined the team as the program manager in May. Of course, we lost our wonderful public health advisor, Margaret Patterson. She bailed on us and went to CDC, daggone her. But we miss her, and she left a huge void in Kentucky. And we were very privileged to have her the 4 years that we did. However, we do have still great advisors in the TB world nationally that we can call on at any given moment that are there to help us in need. And then we were very fortunate to gain a nurse educator in October. Miss Lindsay Pappas joined us. She came from the Lexington Fayette Health Department. She was the TB coordinator there for almost 5 years. So she brought expertise and knowledge to the TB state program. And of course, we have Miss Maria Dalby, who was our TB National Nurse of the Year. Woohoo, Kentucky, Maria. And then we have a couple of others that have been with the team several years. I'm going to give recognition to Teresa Goins, who is our, I like to say our data analyst. She is a systems development coordinator, but she's your NEDS guru. And of course, your RP guru, and those of you in the TB world know what I'm talking about. And then Miss Tammy Hall, who basically, she's our, she keeps us all in line and tells us you need to be in this room for this conference, and you know you switch to this room. So she really is our administrative assistant 3 that takes all the phone calls in, and I just want to give a shout out to all of the team because it truly has been a transitional 6 to 7 months. So what we did, we thought, well, let's start back at the basics. We know communication is always the basics for any program, and so we've been very busy updating our website. So I'm going to give you a couple of little teasers here. I don't have a PowerPoint, so I apologize, but look for our website. It's under construction. Literally daily, new little things are added to the website, moved around, but our goal is so that it's very user-friendly. You know, we have 2 populations that we really wanted to focus on. That, of course, is our local health departments, so the nurses out there and the physicians from the local health departments. We put our little hat on and said, what do they need? What would they be looking for? Where can they find it easily on our website? And then the other is the general public. So you're going to be seeing additions. All of our forms will be easily found on our website. All of our tools for TB will be on our website, so look for those. And we're going to have more of an announcement about our website in January because we're updating our newsletter, which is really exciting. We have a new format. We expect our first edition to come out in January, and pretty much it's going to be a meet and greet. Again, just let you know, put a face to a name and to the duties of all of our TB staff. And we'll be focusing on our training calendar for 2014. Yes, now that we have a nurse educator and we're fully staffed, we're going to be hosting all those wonderful trainings that you have been accustomed to all of these years. The exact dates are not completely nailed down for 2014, but we know which months those will be hosted in, so we'll be able to give you some save the dates. So that's really exciting. We have a new logo that we will share with you with the newsletter. Let's see. Oh, and then also World TB Day is in March 24th every year. So we'll talk about what we're going to be doing here in Frankfurt. So that'll be exciting. And hopefully encourage you to promote World TB Day back in your home counties. And then, of course, you may have received, well, I know you did, an email from Dr. Brawley last night. So hopefully you'll go back to your desk and open that up. It's in a very, very exciting time. We are amending some current TB regulations, and we're also proposing a new KRS. This is very exciting. Of course, all of the TB guidelines are not new. They've been out since 2005 from CDC, and we need to update our current laws to reflect those guidelines. And the TB team actually started, over a year ago. Margaret and Maria and Dr. Brawley really digging back and trying to look at those KRSs and really amending the most important ones to be reflective of the current guidelines. And Dr. Brawley sent out an email last night to gain your input, because in the how does a bill become a law and how do you amend those laws, in that process, when you take an amendment to a committee, you have to have public comment. It's open. And we thought we would be ready to send it across the river, as we like to say, to Capitol Hill in Frankfurt this month, but as things happen, we're going to probably have to wait till May. So under the advisement of OIG, who's actually really been working with us hand in hand as we do these amendments, they said, why don't you go ahead and open it up yourselves for comment? So we did that. We know that TB just doesn't happen to local health department patients. We know that it is statewide, and a lot of our communication daily in TB is not only with health departments, but it's with private medical providers, hospitals, correctional facilities, long-term care facilities, seriously, on a daily basis, trying to determine, is this suspect a suspect or a case? So we opened it up for comment to the Long-Term Care Facility Association, the Kentucky Hospital Association, Kentucky Pharmacy Association. We have already received their feedback. It's positive. We are so excited. Nothing that says, no, we can't do this or anything, and I'm going to tell you what the this is in here in just a moment. So now we want to hear your comments from the health departments. What's changing? Let's see, watch my time here. The KAR 902-2200, we are amending, and that is to establish TB testing requirements for long-term care residents. Why is that important? We want to know, before we admit a resident into a long-term care facility, have they already been exposed to TB? Have they been tested for TB? Because that is a high-risk conjugate setting, just like our prison systems. And there was not anything that said, thou shalt test these individuals before we bring them into this high-risk area. So we are amending to say that they should have a PPD or a blood assay, and those of you in TB world know what I'm talking about, at 2 months after entering the long-term care facility. Also, we're recommending 2-step testing upon admission, and that can be either the first TST or a blood assay, or they could have had one up to a year, and I'm looking at Maria to keep me on track, and then you do the second step upon admission, and then serial testing thereafter. And then also we are amending that if they had had a previous positive TST or blood assay, or if upon admission they have and they're discovered to have a positive, that's considered a converter, and they can't take the preventive medications, we're changing the rule that says you have to do a chest x-ray. From now on, you don't have to do that chest x-ray. This is still long-term care facility residents. And we're just saying monitor their signs and symptoms annually, 6 months, and then 2 years thereafter. So that's huge in the long-term care facility world, not having to do those chest x-rays. Now, the new regulation is for healthcare workers. Believe it or not, there wasn't anything that said thou shalt have a PPD before you come to our establishment and work as a healthcare worker. Everywhere has always done it. It's been in their employee regulations, but there's never been an official KRS that has said that. So we have created one. And it will say, we want you to do 2-step testing. And again, we want you to do 2-step testing on everyone, regardless of their age. And again, the same as I said with the long-term care facility resident, if you'd already had one within a year and it had been negative, we'll accept that. But yet we want that facility to do that second step. And remember, If it wasn't documented in the medical world, it's considered not done, right? So you cannot take that verbal word of that highly or new employee that they had had a negative in their past. They must show documentation, or you must do that first step, or a blood assay. And remember, we're going to suggest that you're doing the risk assessments, and we're really recommending the blood assay because you don't have to do the two-step. Let's see. Also, is that covered on that? I think I got it on that. Okay. So what we're doing, what Dr. Brawley in his email said, we want your comments. Please review those. We are very interested in your comments, your suggestions. We want you to send those suggestions to Maria. She's compiling everything so that we're ready. When we go to health and welfare in May, we will already have all of those changes made in to those regulations, and hopefully they will pass, and in 2015, legislature will pass them. That's what our goal is. So we have open comments from you until January 31st. I know you're busy. I know there's so many other things that you're doing right now at the health department, but we really value your input. Also, another little reminder, Teresa Goins sent out to the TB coordinators and directors and nurse leaders on December 6th. Don't forget, it's end of the year reporting. She sent you your packets. That's to do your meds data entry, and your ARPIs will be due. She gave you those dates. Let's see. Meds data should be entered by January 15th, and TB World, you know what I'm talking about. And then ARPI reports are due to her by February 3rd. So it's a busy world right now for TB. We're very excited. We can't wait to get all of this information and share it with you on a regular basis. Again, don't forget, we're here every day. We now have 3 nurses in our program. We can take those calls. You're not out there alone in the world of TB. We have national medical consultants that we speak with pretty much weekly, if not daily sometimes. And some of you out there, I see Alicia, she's nodding her head. Yes, hi. I mean, it is. TB is complex. We know that. Treatment is no longer 6 months anymore. It's 9 months. It's 18 months. They're resistant. It's really so much. And those counties that have a high incidence, we still talk to them weekly because it's too much for one individual to know. And then like I said, we have national medical consultants that we, we feel like, well, we do. We're on a personal relationship with them because we know them so well. And then those counties, don't let your guard down is what I want to say. If you've not had a TB suspect or case in 4 to 5 years, the way the incidence is happening, it could be you tomorrow. So don't let your guard down with TB, and we'll keep you there. We'll hold your hand if you do. Just give us a call. Does anyone have any questions for me? That's pretty much it. I left you with a lot of teasers there, didn't I?
Emily, this is Amy at Bracken.
Hi, Amy.
Hey, how are you?
I'm good.
Will the blood assays be made available through the state lab?
No, ma'am. Sorry, we do not have a contract now to do that, but thank you. But, however, through, you can usually get a discount through labs. I'm looking at Maria.
The more,
You want to join in?
volume, yeah,
The more-
by volume, the more tests that you do, the cheaper the price.
Right.
And Amy, you should have gotten an email from us at some point giving you those 2 reps, and you can work with them to get their prices.
I'm having Maria come on up because I don't know if you heard her. I'm going to have her repeat it, but the more you do, the more volume, the cheaper the rate. So I'm going to have Maria mention that.
You should have seen a email not too long ago with the letter allowing the blood assay to be added as far as the TST, so you could do either or. Because a lot of folks, when we had our Tuprazol shortage and our RNA shortage, we had to move to the blood assay. So we got OIG to help us do an amended emergency amending to allow the blood assay to be done. And in that process, we sent you guys an email with those two folks' information. And I don't want to say they're the
Oxford and Croydon.
Well, I don't want to. Yeah, we can't push either one. You can contact either one, but the information is in your emails. And if you didn't receive that, please let one of us know, and we'll be glad to send that information to you. But the more you order, the less the price. They do honor an S&TC price of $48.50, and the Margaret and myself went with Medicaid, and we got it approved through all plans of Medicaid, and it's also approved through Medicare. So any insurance that's paying for a skin test, they will pay for a blood assay now.
Okay. Okay, any other questions from the field or in the room? All right, well, thank you. Everyone have a Merry Christmas and a nice New Year.
Thank you, Emily and Maria. Now comes the time for the nursing office updates. I've got 4 bullets listed on here, and in the last few days since I've sent out the agenda, I've got about 4 more updates. So lots of things popping around here, but it's important, I think, to provide this information to public health nurses as it becomes available. So I hope it's okay if I add those on at the end as a PS as far as the agenda is concerned. First, I'd like to introduce Danelle Bray. Danelle, if you want to come up here with me, thank you so much. I am fortunate in that Danelle Bray is going to be helping me out in the nursing office on a part-time basis. She still will be located and housed in the Center for Performance Management, but she's also going to be helping me, particularly on the public health nursing ITVs as well as the NEC meetings. You might receive emails from Danelle regarding certain updates or projects or initiatives that we're working on. Danelle has a background in local health departments and home health. She was a member of the QIT team that went around and did the site visits. She is with, like as I mentioned, the CPM now and helping out with the nursing office activities. I'm very fortunate to have Danelle. I couldn't have pulled off this month's ITV without Danelle. So thank you and welcome. If you get an email from Danelle from the nursing office, that's what it's about. She's helping me out, collect information or whatever. So thank you, Danelle, and welcome aboard, and I'm so glad to have you.
I'm glad to be here.
Right. Thanks, Danelle. Next, a quick update on the NEC activities. Wanted to bring to your attention 2 projects that we're working on right now. We did take the month of December off because of a lot of things going on, but we'll be meeting again in January, full steam ahead. In January, we'll review our last round of teaching sheets and forms that are in the CCSG. We have one more batch of those to review as a committee, and we'll be working with the program folks to review those and update those. We want to make sure that all of the teaching forms and documentation forms in the CCSG are reviewed at a minimum and revised appropriately every 2 years. So we're working on that. You will notice kind of a segue on the points to remember. Those were, when they were revised in July in the CCSG, there were some folks who could not print those off without them going to a second page. And so it was a formatting issue. So Mary Mullins has revised those. If you have 2 sheets or they won't print off properly, if they hadn't printed off properly in the past for you on the points to remember, you might want to go back and revisit those and reprint those off because they should print for you now. The other part that we realized very quickly as a part of our NEC review of the forms was the Spanish forms of the points to remember. Those were outdated, so we wanted to let you know that those have been reviewed and revised this summer, and those have been posted now. I think they were previously dated 1990, so We got those out on the internet, and I apologize that those got away from us, but they are current. And so if you haven't printed out the most current ones, please go out to the patient teaching sheet forms line hyperlink in the CCSG and reprint those most current forms. The second deliverable that the NEC is working on that I wanted to update you on was that we have heard from several nurse leaders, local health department nurse leaders, that they would really enjoy and appreciate a face-to-face one-day meeting, perhaps held here in Frankfurt. And so I've heard that the nurses, they miss that opportunity to network, and although ITV is wonderful and cost-effective and cost-efficient, they do want to see one another. And so we're working on, and actually decided on, a speaker we're looking at around March. And so what we'll do is send out a save the date in the very near future. It'll be one day. It'll be the speaker will take care of that, and a box lunch will be provided. So really it would just be the cost of travel and overnight accommodations if you needed those to be able to participate. It would be a CE offering, and so it'll be a chance for us to get together. I'll invite the DPH nurses as well, get together and spend a day and face-to-face with some old friends and some new friends. So we're looking forward to that, and again, that is one of our NEC deliverables on our charter this year. I wanted to mention that, and this was one of the first things Danelle did, was to identify the dates for the 2014 PHN ITV calendar. Notice the times are the same, 9:30 to 12:30 Eastern Standard Time, the third Thursday of every month. They'll be held here for Joan and Joanne here in DCLCA. The MRN number will always remain the same. And so you've got the dates there. I attached this with the email. The April date is the 24th. The third Thursday that month was actually, it coincided with KPHA, which is going to be held April 14th through the 17th of next year of 2014. So what we did was we just moved the PHN ITV ahead 1 week. So it's actually the fourth Thursday of that month right to now. So February, April, June, August, October, and December are the dates. So you can go ahead and mark your calendar to go ahead and plan on participating with us next year on those dates. Okay, let me get to my new stack. I received information from Sandy Clark, who is the coordinator of the school health program and section supervisor in one of the branches in maternal child health, and she sent this update to me on the KBN insulin delegation regulation 400. The KBN practice committee met on Thursday, December 12th to review the training module, and that's on the insulin delegation to unlicensed assisted personnel, to review the training module and vote on the regulation change. The practice committee voted to approve the regulation with the following changes. Have a start implementation date of the 2014 school year. Unlicensed assisted school personnel may only give insulin via insulin pen or pump, not vial or syringe. Unlicensed assisted school personnel must pass the skills competency test at 100%. So again, this is information that came from Sandy Clark from the latest KBN work group update. She did send as a PS on her note to me that that she had received information that Bob Dameron and Julie Denton, both Kentucky legislators, have also submitted bills related to insulin delegation. So you all may see that legislation that's going to be out there. So it'll be a busy session on that topic on insulin delegation. Specifically, it looks like to UAPs in this regard. So any questions on that information, please refer those to Sandy Clark. As I mentioned, I did want to give you an update. I had not heard that those those caveats have been added. So I wanted to make sure I brought those to your attention. Next, I wanted to announce that the annual Women's Health Update will be held on Tuesday, February 18th from 9 to 12:30. I believe you all may have already received the save the date for this. Joanne, did you all get that yet? Okay, I'll follow up on that. But it's Tuesday, February 18th of 2014, featuring updates on cervical cancer screening, breast cancer screening, KWCSP. It will be available live here in Frankfurt as well as available ITV. So if you'll go ahead and mark your calendars, more information, including the agenda and the train number, will be forthcoming. Okay. Next thing in my stack, I sent this out. There was a recent Gallup poll that stated that the public continues to rate nurses as the most trusted profession, according to this year's Gallup survey that ranks professions based on their honesty and ethical standards. Nurses are on the front lines of health care. We advocate on patients' behalf, whether we are at the bedside or in the boardroom. Patients understand that nurses are committed to improving the quality of their care, and this poll reflects the high regard they have for the profession. So congratulations to all the public health nurses, and keep up the good work. I think we've had the run on that for many years in the running. Last, I wanted to mention, just make sure that everybody received this information, this memo. If you haven't, let me know, or let Janice Hill know with the DPH diabetes program. The memo came out in early November from Kim DeCoste, who is a previous public health nurse and CDE with the Madison County Health Department. The memo discusses that effective November 1st of 2013, the Kentucky Board of Licensed Diabetes Educators have been authorized to begin accepting applications for and issuing licenses to practice diabetes education. Now note, this is different. This is a licensure board versus a certification. So the memo describes the 4 circumstances that they will, under which people can apply for applications to become licensed to provide diabetes education. But in the bottom of that first page, I wanted to bring to your attention, this is in italics, if you are a physician, a nurse, a pharmacist, dietitian, nutritionist, student in an accredited training program in those professions, or hold another Kentucky license that includes the practice of diabetes education, you do not need to acquire a license from the Board of Licensed Diabetes Educators in order to continue practicing diabetes education. So this would be for somebody who isn't in those particular, doesn't have a license in those particular disciplines, but they do provide diabetes education. So you must become licensed, and the deadline is by July 1st of 2014. Jennifer Hutcherson's name and contact information was included in that memo. If you did not receive that memo, or if you have questions, please refer those to Janice Hale or Teresa Wren, and they'll put you in touch with Kim DeCoste. So I think that's all my 4 initial updates, and then my four extra updates. Are there any questions that you all may have for the nursing office about what's going on? We've covered a lot of topics again today. There's always so much going on, and there's never any there's never any problem filling up the agenda very quickly, because there's always so much to talk about. Anything else? Okay, the next PHN ITV will be held February 20th of next year at 9:30. So thank you very much. Happy holidays, and we will see you in 2014. Bye-bye.